is a practice management webinar sponsored by Upside Health. And before we get into the webinar, I just have a few announcements. We are still planning on doing our Dallas course. We are having a venue change. So just if you're interested, sign up sooner than later because spaces will be limited. And we're going to still have the virtual component. So just email me if you have any questions about it. In addition, we have a new ultrasound course in July on a Sunday in Brooklyn, New York in my office. Hope to see you there, as well as the Aspen conference in Miami in June. So if you have any questions or any boards are coming up, if you're stressed about something and you have some questions about the different plans we offer, just email me or reach out to me on the website. So today, we're fortunate enough to be joined by Rachel Trobman, who is the CEO and co-founder of Upside Health, a digital health company working exclusively in the pain management space, whose product branch has been used by tens of thousands of patients. In addition to leading Upside Health, Rachel's been on the forefront of digital health legislation and collaboration with CMS. We also have Carrie Nixon Esquire, who is the co-founder and managing partner of Nixon Gwilt Law, a law firm focused exclusively on healthcare innovation. Carrie is an industry leader and expert in healthcare law and policy issues related to remote patient monitoring, telehealth, and ML apps. She's played a pivotal role in the development of evolution of digital health billing and the codes that we're going to be discussing today. And I think they're both a wealth of knowledge and information, and this is going to be a lot of fun. Rachel and Carrie, welcome to the webinar and podcast, and please.
Thank you, David.
Thank you, David. It's been, I hope this provides a meaningful and memorable evening for all the participants. I'm gonna quick share my screen. So before we get started, just a quick notice that nothing here today constitutes legal advice, and it's purely for educational purposes only. So David, can we do a quick poll?
Sure.
I am wondering how many of the participants here have used digital health in their practice. And for the purpose of this evening, digital health covers everything from clinical decision tools, schedulers, telehealth, and apps. Let's exclude EHRs because I'm pretty sure everyone here has used that. Able to put out the poll?
I thought it's out. Okay, give me a second. Relaunch poll. There we go. See it now?
Oh.
There we go.
Get the results.
Yep. So it looks like 75% have used digital health before.
Great. And the question for those who haven't is why not, right? Is it because you think it's too time consuming? You're not sure if there's value. Perhaps you don't think your patients are going to be using it. Can you quick answer that question? And even if you do use it, do you have one of these concerns? All right. Any responses?
I think the majority feels that they're worried that patients won't use it.
All right, well, that's a legitimate concern, but it should be noted that digital health does not need to be scary, time consuming, or only for millennials. And it does have substantial value, and you probably know that, and that's why you're here. In fact, digital health has had such an impact on outcomes, patient experience, patient satisfaction, and value, so much so that 80% of Americans would prefer having a remote patient monitoring program. And when it was used at UPMC, patient satisfaction ratings increased to over 90%. Also, there were decreases in readmissions and really the ability to generate new revenue streams. Today, we're going to be talking more specifically, though, out of the whole digital health landscape on a specific types of care management codes and care management programs. Specifically, I'm going to be talking, and Carrie and David, on RTM, which is remote therapeutic monitoring. Perhaps I think the newest of all the codes we're going to be talking about. RPM, remote physiologic monitoring. BHI, which is behavioral health integration. SAMD, which is software as a medical device. And I'm sure here everyone knows CMS, but they play a big role, Center for Medicare Services. And the basics really are, what's RPM, what's RTM? So we said RPM is remote physiologic monitoring. What's RTM? Remote therapeutic monitoring. And across the board, you need to know whether they are medically beneficial and necessary. If they're medically beneficial and necessary, that's a good place to start. Successful RPM and RTM programs need to have written consent from the patient, and that can be done with just through a form. You have to, through RPM and RTM, document the data that's captured. So if the data is being captured through a medical device or patient reported in the case of RTM, it needs to be documented somewhere. There needs to be a degree of patient interaction, and that patient interaction is different from telehealth, and Carrie might touch upon that a little bit later. The data needs to be reviewed by somebody. So
Rachel, can I interrupt?
Yes.
I have a question. The first item is medically beneficial and necessary. So to implement this, do we need some sort of letter of medical necessity or prior authorization?
No, so it varies from insurance to insurance providers, but by CMS standards and most of the private payers or commercial payers we've worked with, there is no pre-authorization needed.
I see.
But from a clinical standpoint, 100% of the patients in your practice wouldn't be necessary for, but in most cases, most patients, at least with our program, it is medically beneficial and necessary. In the case of COVID, right now, providers actually can opt to waive patients' Medicare Part B copay as part of this program. But the most, I think, essential part for a successful RPM and RTM program is it should be easy to use. If it's not easy to use for both the clinicians and the patients, no one's going to use it. But there are some key differences between RPM and RTM. And the first is who can implement these programs. So for both the clinician and specialty level. So RPM, remote physiologic monitoring, doesn't have limitations necessarily on the verticals that can integrate it. Whereas RTM can only be used in the case of respiratory or musculoskeletal. Also, there are certain clinicians who can order RTM versus RPM. So RTM is an E&O code, if I think I'm correct. And that means that, or is a general medicine code, meaning that physical therapists, occupational therapists, psychologists, as well as MDs can implement that. Whereas in the case of RPM, RPM cannot be prescribed by those specials or by those types of providers. Additionally, when it comes to RPM, the medical device needs to be, you need to use a medical device as defined by the FDA. And that medical device has to capture a physiologic metric. So what's a physiologic metric? Pulse ox, blood pressure, weight, heart rate variance, just to name a few. What is not a physiologic metric? Patient reported data, medication tracking as a contrast. That is what RTM is, as long as it's gathered by a medical device. What it's not across anything is like step count from a Fitbit. That would not constitute RTM or RPM. And then the other thing right now is who can review the data as part of this care. And that's an area as well that I think David, Carrie, you're probably going to get into a bit later. And with that, I'm actually going to turn it around to David and Carrie. Carrie is a a wonderful friend of ours, a fearless leader in the space of digital health, and someone who knows an exorbitant amount on the subject. So I'm glad for her. I'm glad that she could join us today.
Thank you so much, Rachel. It is a delight to be here with you, and David, with you as well. Why don't we go to the next slide and I'll dive in. I thought it might be helpful to sort of set the stage as to where we came up with these virtual care management codes like RPM, like RTM. They all started way back in 2013 with what's called transitional care management. It was the first sort of virtual care management service that was separately reimbursed. And the purpose was to really manage the care of a patient that was in transition from one type of care setting, for example, a hospital, to another type of care setting, for example, the home. And the thinking was that high touch with that patient would actually help to make sure that the patient was transitioning well and didn't end up back in the hospital. So that happened in 2013 and was the first of the virtual care management codes. Fast forward to 2015, and we saw a new code set come out called chronic care management codes, where patients who had 2 or more chronic conditions could benefit from high touch and continuous sort of touch throughout the course of a month and ongoing by clinical staff members and their physicians and their practitioners as part of managing their care. So developing a care plan, checking in with the patient to make sure that they are following that care plan, and then intervening if they were noticing any type of problem before that problem became too much of a problem. So 2015, chronic care management. 2016 and 2018, we saw the advent of care management really in mental health services and behavioral health services. And the thinking here was that patients, again, could benefit from a higher touch from members of their care team who were involved in managing their mental health, particularly as it might impact other parts of their care, right? And as they were integrated into their primary care practice or other type of, disease that they were struggling with. The thinking was that sort of in mental health was very important if chronic conditions were going to be treated appropriately. If chronic conditions might lend themselves to depression, if that depression isn't managed, then the condition worsens. Now, sort of the moment that Rachel has certainly been waiting for is 2019, the advent of the remote physiologic monitoring codes, which she mentioned before. And that is where you have a device that is collecting patient-generated health data. So, for example, a wireless or a Bluetooth-enabled blood pressure cuff for a patient who has hypertension, for example. We're going to use another example in the pain management space, but I'm going to give you a really easy one to wrap your mind around it as an initial point. That patient might see variations in their blood pressure over the course of time, and there might be sort of spikes that over the course of a month and several months when a care team is managing it, they are able to identify those spikes and again intervene to maybe change medications to change the protocol. Fast forward to 2020, we saw principal care management. We talked about chronic care management as 2 or more conditions. Principal care management really focuses on a patient with a single, potentially not as long of a time duration, potentially even an acute episode. So for example, maybe a cancer patient, right? Or for example, maybe a substance abuse disorder patient, for example. 2022, the remote therapeutic monitoring codes came about. The distinction, as Rachel mentioned, between RPM and physiologic data versus therapeutic data is really that remote therapeutic monitoring codes are measuring things like adherence, things like pain, things like mood, things like how are you doing with your therapy protocol? How are you doing with your medication regime? How are you doing with the drugs that you are prescribed and that you should be taking? So
Can I clarify?
really, yeah, go ahead. Go ahead, David.
So these are different subs, like each of these has its own subset of codes, like the RTM has its own codes. Can you just explain to them how they're structured, why they exist, how they came about?
Absolutely. So each of the types of care management services that are listed here on this slide are reimbursable under the fee-for-service sort of protocol, the fee-for-service landscape in healthcare that physician practices and therapy providers are used to. We all know we're sort of shifting more to a value-based realm, but right now we live in a world of CPT codes where when services or devices or treatments are ordered, they are put in with a CPT code, a claim is made with that CPT code, and that CPT code has a certain amount of reimbursement assigned to it for that service. So it is a big deal for these virtual care management codes that they each have sets of CPT codes that are associated with them that provides reimbursement for the practitioner that is ordering those codes. So
Can I hop in for
many practices, go ahead, Rachel.
Also, one of the things I think is really interesting too about these codes, RPM and RTM in particular, is that, as Carrie mentioned, there's actually individual codes for the different types of services within the codes, meaning that it offers more opportunity for engagement and more opportunity for reimbursement based on adoption and adherence. So let's say a patient is transferring the data, but that data isn't necessarily being reviewed as frequently. That doesn't mean that the whole program is off. That just means a section of the codes can be billed, but not all of them. Or in the case where you're adding additional time, there's additional X codes or supplementary codes for more time spent reviewing the data. So it allows for you to build like a robust program that's a bit more dynamic based off of utilization.
Are there limitations as to which type of physician can bill which type of codes?
So only when, not the type of physician, no, that is not the case. The type of practitioner, yes. So as Rachel mentioned at the beginning, practitioners like physical therapists and occupational therapists and clinical psychologists are not, they are only able to bill certain code sets under of CPT codes. Physicians, on the other hand, have a much broader range of codes that they are typically able to order and bill for. Physicians, nurse practitioners, physician assistants can all order and bill for the remote physiologic monitoring codes and the other care management codes, chronic care management, principal care management. Remote therapeutic monitoring codes can be, in addition to nurses, nurse practitioners, PAs, and physicians, can also be ordered independently by physical therapists, occupational therapists, clinical psychologists, etc. So there's a little bit of a distinction there.
I see. Okay.
So let me transition to a little bit about sort of the way these services and these programs can be typically implemented in a medical practice. So, for example, a practice that's implementing a remote patient monitoring program is generally responsible for educating the patient about how remote patient monitoring works, physiologic monitoring works. They are responsible for supplying that patient with a medical device or devices to monitor their condition. And they are responsible for monitoring the data that is coming in through the connected device and interacting with the patient around that data. Hey, Mrs. Smith, I see that your heart rate has been really high and you're showing some anxiety. That can be your heart rate variability is indicative of anxiety in you. What's going on right now? To make that happen. And Mrs. Smith, talks a little bit about what's going on and they figure out how to get that condition under control. So each of those components that I just described to you, patient education on how to use the device itself, and the monitoring, each of those three things are independent reimbursement codes, CPT codes, that can be billed on a monthly basis, with the exception of patient education, that's just one time, But the device code and the monitoring can be billed on a monthly basis so that the practitioner who has ordered the monitoring is able to have a more continuous touch with that patient as part of managing their care. Does that make sense, David?
Yeah, it does. And this I see on the slide, it says it. So this is an outsourced type of thing, more or less, like who's
It can be.
setting it up, like how, okay, I prescribe it, and then what do? I put them in a portal, the patient's information in a portal, or have my staff do it, and then the third party, for example, your company or someone else
Yeah.
contacts the patient, and how does it work? I mean,
Exactly. Let's go back to the previous slide, just one moment. When the remote patient monitoring codes first started out, the very first year that CMS put out the codes, they made it such that the physician's practice, the clinical staff within that practice would have to be responsible for doing the monitoring. Practices said, our clinical staff are already overburdened. They are swamped. They don't have time to do this. This is an impediment for us implementing a really effective remote patient monitoring program. We would like to outsource the monitoring of the data, sort of the daily monitoring of the data and the tracking it, and some of the general interactions with the patients to the vendors of remote patient monitoring services, like Rachel's company, right? So to say, we only want to hear from the outsourced clinical staff when something is up, right? When there's a problem or there's a question that arises. That's when we want to be notified by the outsourced clinical staff, our practice, and then we're able to say, hey, let's make a change here to intervene for this patient. Fortunately, CMS made that change, allowing sort of these outsourced clinical staff to be providing the monitoring services. And this has really had a positive impact on adoption of remote patient monitoring programs, because the easier it is for a medical practice to implement a program without burden to their existing sort of day-to-day practice, the better off everyone is going to be. So now we can go to that next slide, and this will just give you a sense as to how sort of the business model works. I'm a healthcare lawyer. I get a lot of questions from physicians or practices who are looking to implement these programs. They go, oh my gosh, is this legal? Is there going to be some kind of a kickback arrangement that's happening here? What's going on? Like is this okay? And so I put together this diagram of sort of how the business model works. So the box on the left is a vendor of remote patient monitoring services, for example, like Upside Health. That vendor of remote patient monitoring services may be providing a software platform, right? A portal where the clinician can log in, maybe even the patient can log in for use with their monitoring program. They're going to be providing a device or devices for monitoring purposes for transmitting the data. And then they are likely, unless the practice doesn't want them to and wants to bring it in-house, likely going to be providing monitoring services as well. So clinical staff, outsourced clinical staff who are monitoring the data. So those are the three arrows that are going over to the customer medical practice, the RPM customer medical practice. In exchange for those services for which the RPM practices are receiving reimbursement, in exchange for that, the RPM practice is going to be paying a services fee on a per patient per month basis. This is typically how it works, not how it has to work, but it's typically how it works, for the platform, the device, and the services. And that is a perfectly safe, perfectly compliant arrangement in accordance with the healthcare laws.
is there a scalability, meaning if you have X number of patients, this is the fee, if you have more, it changes, or just strictly this amount, dollar amount per patient, end of story?
It is, so usually it's per patient per month. If, for example, you're dealing with a very large practice that has a very large pool of patients that might be eligible for a monitoring program, it's possible that there could be some economies of scale in sort of the more patients that go on to the program, the actually less it costs sort of for the vendor, for example. So maybe you're shipping, more like there are economies of scale in shipping more devices and providing more services to a particular customer. And so you can sort of account for those economies of scale potentially in pricing arrangements, but by and large, it's generally a per patient per month services fee that's keyed to the fair market value of those services. All right, so this slide talks about going even further in a practice's relationship with a patient. We talked about one way is, a remote patient monitoring program, whether that's remote physiologic monitoring or remote therapeutic monitoring. I mentioned principal care management services earlier. If, for example, a patient is dealing with a condition that involves chronic pain, maybe they don't have any other chronic conditions, but they do have chronic pain, a single condition. That condition can lend itself to monitoring with a device. It can also lend itself to principal care management services. So under the schema of these CPT codes, CMS has said remote patient monitoring works really well with care management services, like other care management services, like principal care management or chronic care management. And so we know that for some patients, they're going to need not just the remote patient monitoring, but also maybe the additional layer of principal care management services, which means we're going to be really drilling down into the patient's care plan. We're going to be maybe even considering some of the social determinants of the patient and helping to manage those things. The communication is going to be very centered on things that don't necessarily involve the patient data, but maybe involve more care coordination. So as I mentioned, the principal care management services are also a set of codes that are eligible for reimbursement. So it is possible that if a patient is going to benefit from both monitoring services and principal care management services, then that's sort of a dual revenue stream. I think that's enough for me on this for right now. But so let me go back and pass it off to Rachel to take sort of the next pass of what we're going to do here.
Yeah, well, I think that the next, the natural segue is here. So great, all these things work in concept, right? We've cleared that they've been established. We've cleared that they're legally sound to some, to the degree in which we're speaking about today. The question is how does it actually work in practice? And I wanted to talk a little bit about some of what we've learned implementing with, tens of thousands of patients at practices like Dr. Rosenblum's and elsewhere, and really what has worked for us and then what the impact has been. And there's a lot of text on this screen, but it should highlight the key points. Was one that we found is patient minimums. Right. So we get a lot of questions. Well, can we just start with 30 patients in our practice? And if there's 8 doctors, right? Our philosophy of what we've learned is it should become a part of your care. And that's really hard to do when there's just 30 patients. And so normally when we're working with clients, we have patient minimums associated with that. And that's not because we want to be a bully, but because what we've seen is when everybody is bought in equally and everybody has worked this into their plan, it becomes a lot easier and more valuable across the board. Second is really being a partner and having clinicians find a partner, not just like us, but similar, that really work on clinical workflow and implementation with your practice. So any company that comes to you and says, this is the way we do it, and this is the only way we do it, it might be difficult if your practice runs a little bit differently. And so finding somebody who learns about the way that your practice runs and works with you to figure out how the solution fits within your practice is probably going to be the most successful. Third, we talked a little bit about monitoring and principal care management, and about how normally somebody else is doing that monitoring. Really working clinician or practice manager and vendor partner hand in hand to make sure the script or what the monitors are saying to the patients during that interaction feels organic and authentic to the way that you run the practice. It just allows for a more integrated program. And then the fourth thing that we see is really pre-screening. So reviewing the patient list and saying, 2 weeks out, here are the patients that we think would be good fits for this program, and also clearing like, yes, their insurance is covering this. That way, then you can make that clinical decision whether this is medically beneficial and necessary. But having that extra set of hands based on people who have seen the program being successful. And then lastly, is this program a good fit for your vertical? Meaning bringing a blood pressure program necessarily into a pain practice, like how is that going to change and evolve your care plan? How is that going to modify?
First of all, that's something that they'll cover, because if you know what, we see people all the time with elevated blood pressure. Now, given I'm not managing their blood pressure, but if we see a bad trend, it will alert us to tell their internist or to have them follow up with someone, and therefore their care would be positively affected, even though I'm not writing the beta blockers myself.
Sure, but the possibility is a patient can only use one physiologic monitor, and so their primary care provider may be monitoring their blood pressure. So it's really, in our case, right, we found that remote physiologic monitoring with a heart rate variance monitor was actually more insightful for across more patients. And then in the case of remote therapeutic monitoring, right, not having an actual additional physical device they had to strap to themselves really helped with adherence and adoption.
I need to picture this as it plays. So the patient comes in, we get them set up, your company contacts them or our company contacts them. I have somebody in my office going through the data.
No, so we have
You guys go through the data.
Right, we have registered nurses.
Are we looking just at pain scores? I mean, we didn't really get exactly what parameters exactly is a pain practice going to be looking at.
Well, so I can speak to what we offer. I mean, all different solutions are offering different products or different data points. In the case of us, in our remote physiologic monitoring program, it's heart rate variance is the physiologic metric. Our promise scores, so scores on pain intensity, pain interference, pain and behavior, mood, and sleep, as well as we can connect with other passively generated data sources. So we do have step count. We connect with Google Fit, Apple Health, and then distance traveled. So we help determine whether the patient has been stagnant and active. Also, our program looks at whether the patient is engaged with any of the behavioral health content within our platform, whether they have attended sessions with our pain psychologists and physical therapists, and whether they've connected with other patients.
Are you able to comment on reimbursement numbers?
So, I mean, 95% of our claims have been reimbursed to date. And we've seen an average reimbursement of about $220 with across all of the codes that we bill cumulatively per patient per month.
$200 per patient per month additionally?
Yeah.
And that's if they come to the office, you bill your regular codes, and then you're also on the back end billing for review of this data, not on the same day or
it's per calendar month. So the data is being reviewed by our team during the calendar month and then is documented. And then normally we provide all of the documentation for your team to sign off and submit for billing within 10 days of the following month.
And you take a fee from that $200. That's after your fee is taken out or before your fee is taken out?
Well, the fees that I'm giving are purely Medicare. I'm not going to get into like commercial insurance, which we've seen as multiples, right, of most of the time for Medicare. But yes, our fee is if you use that 220 number, is after that.
Okay.
Yeah, so the fair market value of sort of the services is in part sort of loosely informed by the reimbursement, general reimbursement of those services. So depending on, for example, whether or not the clinical staff is being outsourced, right? That's going to be a higher services fee than if they're
Sure.
doing the monitoring in-house.
And is there a limit for how long you could do this? Can you do this for 10 years or just as a shorter period of time? Because, these patients, they come every month and they're in pain forever, and they have to get their refills, or they just always have something wrong because they're chronic osteoarthritis, inflamed everywhere. So some of them really are very reliable patients that will be with you for 10, 20 years if they live that long. And the question is, if theoretically this was a good fit for them, is there a point where the government says, or CMS will say, no, enough is enough, we're not doing this anymore, or there's no limits?
Mm-hmm.
You want to take that, or should I give it a crack, Rachel?
Why don't you? Because I know that we've had patients on our platform for quite a long time, and
Yeah.
Continually getting this data and this insight has proven valuable.
Yeah.
That being said, Carrie, I defer to you on your assessment there.
Yeah, so I'll talk a little bit about the policy underpinnings of like why could it be a good idea to have a reimbursable service month over month continuing sort of to no end with a patient, right? The policy underpinning there is that having that continuous touch reduces emergency room visits, reduces urgent care visits, maybe even reduces, general visits to the physician, and certainly can reduce hospitalizations, right? So, and the way that it does that is by the care management, by the high touch, by looking at the data. You are able to intervene and interact with the patient early to stop a problem before it becomes a big problem. So if for example, you think about the cost of a remote patient monitoring program to a payer over the course of a year, you're talking about, $1,500-$1,600, whatever it is, something like that, like over the course of a year, if you were to do it every month for over 12 months. The cost of a trip to the ER, you've already blown that out of the water, right?
I think we get it. I mean, most doctors will, without even looking at the data, understand what you're saying, and it sounds right what you're saying. And I mean, I've had patients go to the hospital because of sciatica and they need an epidural shot and no one's around to do it. And the hospital admits them, and 5-6 days in the hospital till they can either get a shot or just get sick of being there and go home, easily 10, 15, 20 grand. It's ridiculous. So if there's some sort of extra pulse on the patient, on what's going on with them, that someone says, oh, they're really miserable, about to go to the ER, maybe they should just do a telehealth or talk to their doctor first. So that kind of connection is priceless. However, I'm just wondering if they still will cut it off because they cut off the amount of epidurals we can do, when, to be honest, some patients need more than the 3 or 4 that we offer them or that they allow to pay for. So
yeah, well, the key criteria here is whether the physician still deems the service medically useful and medically necessary, right? As long, and CMS has not put a limit on these services. They've, a chronic condition is a chronic condition. It is long lasting. So
We've actually expanded them. I mean, with all these new codes year after year. So I think that
exactly
industry-wide, that's kind of telling in more of the direction they're headed.
Right. And in addition, actually, this year, reimbursement for some of the bulk care management and chronic care management went up by 60 to 80%, whereas reimbursement for everything else was going down because of the belief that these services are valuable in intervening. So the short answer to the question is there is not a specific limit. If you've got a patient who's totally not compliant with the program and it's not working for them, and you just keep them on it so that the money keeps flowing in, like that's going to be a problem, right? Somebody's going to catch on to that. But as long as you have a good case that, the patient is benefiting from this, then you should be good.
I see. Very nice.
So, I mean, this is the end of our, official presentation, but I would love to open it up, for 3 more minutes if anybody has any pressing questions while still being respectful of everyone's evening and time.
We had one question, but I believe you answered it. Can you give some examples of RTM?
Yeah, sure. So remote therapeutic monitoring, in addition to sort of measuring therapy adherence and therapy progression, is also able to to measure patient self-reported metrics, right? And pain is an example of a metric like that. Mood is an example of a metric like that. So, for example, if your software platform has built into it components that are maybe assessing and assisting in treating or diagnosing a condition, that software itself can be called software as a medical device, and it can be the device that is used with remote therapeutic monitoring. So, for example, if you're pushing through assessments about pain scores, right? Like, what are your pain levels? If you're pushing through, how often are you taking your medication? Have you taken your medication? That type of thing. Those are examples of remote therapeutic monitoring. Other examples: physical therapy, occupational therapy, medication therapy adherence, that type of thing.
I see. We have some more questions.
I can grab these two. So the first question I saw was about current interventional pain practice using remote patient monitoring programs, testimonials. Yes, I'm happy to provide them after. And then in regards to, can this platform be used? I mean, just as a quick anecdotal, right? One of the providers said that our product fits an unmet need within their practice, whereas others said that they can really see the difference in the way their patients engage. And then in regards to, can this platform be used to monitor response from pain intervention? Yes. And it's really looking at the way that our platform does it, although there's a lot of others, is we're able to pull when a procedure has happened, an injection, a different type of medication change, and then we analyze differences from both patient reported and the passively generated data following a period of time.
Yeah. Response to therapy, right? Therapeutic response is exactly right down the line for what these remote therapeutic monitoring codes were designed for.
Yep. All right. Well,
Very
David,
nice.
I'm going to turn it over to you, but I'm very grateful and thankful for everyone who joined us tonight. And I'm around if there's any questions or follow-ups that you have.
I think this was great. We're trying to focus not just on board review, but also practice management. And I make a lot of podcasts about this. However, this particular topic, not much on this. And my group is actually in the process of integrating this. So I don't know exactly how it's going to work yet, but we are, doing going through the motions of setting it up. Yeah, I mean, this looks like the future. This looks like this sort of tech and this sort of care is here to stay. So I think, the patients will appreciate it if they see that you're ahead of the game and you're up on the latest ways to stay in touch with them, monitor them, and provide care. I want to thank you both for joining. And your contact information, the docs on here, I'm going to share the emails of the docs who signed in for the webinar. So they'll probably be reaching out to you, but if somebody needs the contact information specifically of Rachel or Carrie, I have that. So you can always email me unless you guys want to give them another way to contact you.
So I'm going to just put in the chat the best way to contact me. However, I'm sure someone from my team will definitely follow up with everyone who's attending today to see if they have any other more specific questions.
Great. And by the way, you can claim CME credit for a small processing fee. Just go to nrappain.org and you'll get 1 CME credit for reflecting on this activity. This is an industry funded activity, and this is not a CME webinar. It's just a separate platform from CMEify, which gives credit for reflections on conversations, webinars, podcasts, or anything else that you've had a chance to learn something new and reflect upon it. Once again, thank you for joining us. Hope to see you at the live board review course, ultrasound course, and online. Take care and good luck. Thanks, guys.
Thank you.